My name is Chanyoung Park, and it is a great honor to present in this year's Megamind. My topic today is step-by-step, evidence-based prosthetic workflow for the implants in the aesthetic zone. To briefly introduce myself, I'm currently a medical officer serving for the Korean Army and also a board-certified prosthodontist. I was also one of the top 20 finalists for the last year's Megamind as well. So the implants in the aesthetic zone, they are commonly encountered cases, yet always difficult. And for the prosthetic success, there are hundreds of factors to consider to achieve aesthetics and function. And this is correlated by many factors like treatment planning, managing gingiva, choosing material, occlusion, and impression taking as well. So let's talk about what we have to prosthetically consider for the implants in the aesthetic zone in evidence-based, step-by-step manner through a story of a firefighter who suffered from a dental trauma. This was his initial state and his final state after the treatment. Now, to achieve this result, the treatment workflow was planned, as we can see. So now let's start the main story. Starting with the patient diagnosis, the patient visited our clinic suffering from spontaneous pain and unaesthetic appearance of maxillary central incisors, which suffered from a dental trauma about 1 year ago. This is the radiographic view, and if we take a look a little closer, we can see some periapical lesions on both teeth, even after multiple endodontic treatments were performed, along with ongoing spontaneous pain. And there were some external resorption on the tooth number 21 as well. And if you look at the intraoral photo, we can see some additional problems, including intrusion and discoloration of the two teeth with unaesthetic reverse smile line and gingival line as well. And due to the thin scallop gingival biotype, there could be some risk of a compromised gingival healing after implant surgery. Well, nevertheless, these two teeth were hopeless to be saved, so extraction and implantation on the two teeth were planned. And if we look at the CT, the conditions are not perfect, but appropriate enough for immediate placements, as there were facial wall thickness about 1 millimeter, almost 4 bone wall defect. Penetration exists, but small enough and quite apical from the crest, while there is chronic periapical lesion without any fistula. So the next step is implant planning and the implant surgery. Now, I believe that every treatment should begin in restoration-driven manner with the wax-up for predictable prosthetic results. So virtual diagnostic wax-up was done. And the provisionalized teeth were a little long and taper-tree, but within the normal limits around the average Korean adult's values. So no additional gingival graft seemed to be needed after the surgery. And double checking with the facial scan, according to the facial flow analysis, this patient showed quite fine facial symmetry. So the facial flow curve and the facial midline almost coincided together, so that the dental midline without any problems could be easily formed coinciding with the facial midline. And the smile line parallel to the horizontal landmarks of the facial features as well. So the implant planning was done according to the wax-up, 3 millimeter apical to the planned gingival zenith, and placed palatally for achieving primary stability as well. So the surgical guide was fabricated, tried in, and implant surgery done along with a little GBR on the facial area. Right after the surgery, we could see that the surgery was done successfully. And for the loading protocol, conventional loading was chosen due to the initial insertion torque value and ISQ values. These were somewhere in the borderline, maybe between immediate loading and conventional loading, but we took a safer route, maybe a little slower dentistry, as conventional loading after immediate implantation may be more of a scientifically validated protocol so far. So the flipper was delivered after the surgery, and if the patient has some high aesthetic needs, Valplast can be a good choice of material. So the next step is managing the gingiva, first part using the customized healing abutments. Now, for successful pink aesthetics, it is important to preserve the gingival volume as much as possible while aesthetically recontouring the gingiva by prosthetic means. And I think customized healing abutments can be a good option compared to the conventional healing abutments in terms of preserving papilla height, midfacial mucosa, and horizontal wound volume. But there are also risks as well, as plaque accumulation could be a problem. And if excess pressure is applied on the healing tissue, there could be chances of some iatrogenic recession as well. So it is important that the subcritical contour of the abutment should be as concave as possible to secure the regeneration space of the healing area and to avoid excess pressure. Following these principles, customized healing abutments were delivered, and after 12 weeks, we can see that peri-implant tissues were nicely preserved, but still, we can see that additional gingival recontouring is needed. And the ISQ values at this point were high enough for occlusal loading as well. So now we are ready to change to the Interim PMMA crowns with occlusal loading. And for the impression method, we chose intraoral scanning with model-free virtual workflow over the conventional method, because systematic reviews say that for cases with short span edentulism, we can acquire commendable accuracy using the virtual workflow while reducing the chairside time and with better patient comfort as well. But I think another major advantage is the simplification of the lab workflow, because in aesthetic zones, it's important to transfer the molded subgingival contour to the final prosthesis. And in the traditional workflow, it is quite time-consuming and potentially requiring more patient visits. But using the virtual workflow, only the scanning of the needed information and superimposition is needed to transfer the subgingival contour to the final prosthesis. So regarding this, intraoral scanning was done using peak scan body under suggested ambient lighting conditions and under suggested scanning strategy to achieve accuracy. And after that, jaw motion tracking was done to record the patient's jaw movement as well. And this jaw data was used to form the anterior guidance of the restoration. And regarding this, the wax-up was done. And for the occlusal scheme, mutually protected occlusion was given. And after double checking with the facial scan once again, the Interim crowns were fabricated, and it is important that the aesthetic zone of the crown should emulate the natural tooth crown shape, while the crestal zone should be concave enough to avoid excess pressure to prevent inflammation of the tissues. So the Interim PMMA crowns were delivered, but still we could observe some problems on the aesthetic as well, because due to the ideal gingival line, the crown number 11 was too coronal from the ideal level, while the crown number 21 was too apical from the ideal level, along with some black triangle issues as well. So by gingival recontouring, we have to correct this as much as possible. So for the strategy, the crown number 11, the gingiva has to be apically migrated, so the critical contour should be a little over-dimensional in the facial apical direction to push the marginal gingiva upwards while keeping the subcritical contour concave enough to avoid excess pressure. And on the opposite, the tooth number 21 should be underdimensional of the critical contour to the facial direction so that the gingiva is creeped downwards to the coronal direction as much as possible. And we have to increase the convexity a little in the subcritical contour at the same time. And finally, for the black triangle area, the convexity of the subcritical contour has to be increased to fill in the black triangle area as much as possible. So following these principles, 3 months after gingival recontouring, we could see some improvements in the pink aesthetics. And we can see that with less signs of inflammation, we could see intact architecture of each zone as well. And we could also observe this on the occlusal view. So now we're ready to fabricate the definitive prosthesis. So what is the appropriate material for the final prosthesis? Well, there are many possible options, but whatever option the clinician chooses, it is important to understand the characteristics of each material. And for the abutment, titanium abutments were the most conventionally used material, but for this case, zirconia abutments with titanium base was chosen, mainly for aesthetic reasons, because if the peri-implant gingiva thickness is less than 2 millimeters, the abutment material may significantly affect the marginal gingiva shade. And many researches support this. And including this study shows that zirconia abutments shows the best patient satisfaction and maybe the least discoloration of the peri-implant gingiva if it is not thick enough. But not only the aesthetic aspect, on the mechanical aspect, zirconia abutments with tight base showed comparable fracture resistances after cyclic loading compared to the titanium abutments. And also for the 5-year survival rate, all abutments performed well. So all these evidences support the use of zirconia abutments with titanium base in the aesthetic zone. And for the final crown, we chose multi-layer zirconia as our option. And as we know, the main feature of multi-layer zirconia is that each layers differ in yttrial contents with different pigment types to express the translucency of the enamel, especially on the incisor layer. Although it has higher yttrial contents and lower flexural strength, the reported values support that it is stable enough to be used in aesthetic zones. And according to the ISO classification, this may be stable up to 3-unit anterior bridges as well. But on the aesthetic aspect, it is still inferior to the porcelain build-up crowns, as it has some limitations in detailed shade characterizations, but still there are some clear advantages of skipping the porcelain build-up, and there may be less need of additional coloring. So it may be a good indication for some cases, like our case, as the adjacent teeth shows less complicated shade characteristics. So the crown of shade can be expressed using the predetermined layers of the multi-layer zirconia with less staining. So after scanning the interim prosthesis and the intraoral data, they were all merged together in the virtual CAD software. And using this information, the definitive prosthesis was designed respecting the subgingival contour while giving the cementation gap about 50 microns and incisal thickness of 1 millimeter. Now, this 1 millimeter thickness is the suggested thickness for optimal translucency of the incisor layer in multi-layer zirconia. So after finishing the design, the prostheses were all fabricated. And first, the customized abutments were delivered along with the PMMA crowns in prior to check the patient's final satisfaction of the morphology and to see if there's any major misfit of the abutments. Everything was fine, so we switched to the final zirconia crowns, both of which were screw mountable types. And to protect the decementation and residual cement issue, it may be advisable to use low viscous, eugenol-free zinc oxide cements. And extraoral cementation may be a good method, but in angled prosthesis, repeated use of angled screwdrivers might decrease the actual torque delivery. So I think it is advisable to open the possibility for the intraoral cementation as well. So we can see that all the final prostheses were delivered with stable occlusion in check, and the smile line blending with the facial features. The patient was overall satisfied with the results. And after 1 year, the patient came back for a recall check, and we can see that all the crowns and the peri-implant tissues are well maintained. And we can also check that the implants were well osseointegrated inside the bone. So now let's wrap up the presentation. For prosthetic success, every treatment should be started in a restoration-driven manner to achieve predictable results. And yes, in the aesthetic zone, pink aesthetics should be of utmost importance, and depending on the loading protocol, we can utilize immediate interim restorations or customized healing abutments for reconditioning of the gingiva. For the final prosthesis, whatever materials we choose, it is important to understand the characteristics of each material so that we can choose the right material for each cases. And if the edentulation is not long, virtual workflow may simplify lab procedures while maintaining commendable accuracy. But most of all, I think every step, whatever the protocol is chosen, should be evidence-based. So these are the references, and thank you for listening.